And finally, slowly approaching the end of my talk, I would like to spend a few more minutes on the issue of reporting, because this is also a key factor. We need to be able to communicate the genetic labs and the clinicians. So each laboratory has its own reporting format. A one-page report is preferred. It shouldn't be too long. There are some general guidelines available, and you see the websites addresses as shown here on this slide. The report should state the methodology, specify the gene, exons, and mutations tested for, and we should be using mutation nomenclature approved by the Human Genome Variation Society. And reports describing novel variants should state that the variant is novel and possibly include the evidence in support of pathogenicity. For example, the absence from a large series of controls or modifications, testing of other affected relatives to check for co-segregation, conservation across species, a character of amino acid substitution. Splicing site mutations can be analyzed using computer programs. Reporting of polymorphisms is useful, however, it's not mandatory. Treatment recommendations are outside of the jurisdiction of molecular genetic report. In other words, when issuing the laboratory reports, we should not be including any clinical recommendations as far as the, for example, medical care is concerned. It is useful, however, to include an appropriate reference if available. And we may be dealing with different scenarios. For example, when reporting, affected proband or a relative and mutation identified, nonsense, frame shift, splice site, or previously reported missense mutation. Affected proband and novel mutation identified, likely to be pathogenic. Affected proband, novel variant identified, however, unlikely to be pathogenic. Affected proband, no mutation identified, and other scenarios that are shown here on this slide. And each scenario requires a specific comment. And I would like to close this lecture by concluding that molecular genetic testing is useful in patients with MODY because it confirms a diagnosis of monogenic diabetes, it predicts likely clinical course, and also it defines risk for relatives and determines treatment. However, at present, molecular genetic testing for MODY is relatively expensive, and phenotypic selection prior to testing is normal practice. With the development of new technologies, it is likely that these costs will decrease in time and that the analysis of genes associated with monogenic diabetes may become routine for newly diagnosed patients. In the meantime, the guidelines should be followed in determining which patients should be offered testing and in the interpretation and reporting of the test results. And I would like to thank you very much for your attention at this point, hoping that all of you, particularly those that came from outside of Krakow, will have fun in our city. Thank you very much.
Thank you very much. That was a very clear talk. Can I ask for questions from the audience?
Maciek, great talk. Now, you say that HNF1 alpha diabetes is lean, and this is what we see also in the US. Now, given that in the population there is, in the US at least, a 25–30% of obesity, one would expect to see obesity also just by chance in those people. So, and we don't. So my question is, do you think that actually HNF1 alpha mutations are protective from obesity? There is less insulinization, so there is less anabolism?
Well, I do not have much of evidence for that. I think that the only mechanism is a severe metabolic decompensation and the loss of glucose in urine. However, those patients are not so difficult to clinically control. I think that there was a very interesting case report from the UK, but Ewan Pearson and Andrew Hattersley about 10 years ago, published in Diabetic Medicine, and they reported an obese guy, that was treated initially with sulfonylurea. Then, because some small deterioration occurred, he was switched to metformin, and then HbA1c went up, and then the genetic testing was performed in the family. Sulfonylurea introduced back, and HbA1c very nicely went down. So I think that what this case is teaching us, that we should not exclude the family or any specific patient from the genetic testing solely on the basis that the obesity is present.
I mean, I would add to that, that one problem is that we very much define the people we test by the clinical features that we've already defined, and then it becomes circular. Oh. So if you don't test it in many obese people, you aren't going to find it. We certainly have some overweight patients in Oxford, and that, you know, I'll talk about that in the next presentation.
Thank you very much. So if there is no any more